So welcome everyone to another episode of Decoding Diagnosis. We're here tonight for a case of chest pain, which will be really great. We are joined by two excellent discussants. I will let them introduce themselves. One is an M3 named Katie, and then another is a repeat discussant who's a PGY-2 at John Peter Smith Hospital, and that's Dr. Mollyanne Brunkow. So Katie, go ahead and introduce yourself. Tell us something that you like that is not really the medicine and your favorite morning breakfast.
All right, hi, I'm Katie. I'm interested in family medicine. Something I like outside of medicine and school is I really love to bake. And my favorite morning breakfast, I really am not a breakfast person, so I struggle with this. But I like chorizo and eggs is pretty good.
I'm Mollyanne Brunkow. I am at John Peter Smith Hospital in Texas. I'm a PGY-2 in family medicine. I graduated from KU a year and a half ago. So something I like to do for fun is feed people. And now that my residency has been mostly all vaccinated, we're starting to have a few people get together very cautiously, and I get to have a couple coworkers over tonight to feed them. We have really good breakfast tacos at the cafeteria in my hospital, and so I would say that bacon and egg breakfast tacos are about my favorite breakfast.
All righty. Well, let's go ahead and get started. We have a person with chest pain, and Drew has already asked the first question. He said, was it witnessed or was it unwitnessed? This was an unwitnessed fall. And so we'll get started with the HPI here. 71-year-old male who was found down in his bathroom this morning around 5 a.m. by his wife. He was washing his face when he became dizzy shortly before falling down to the ground. His wife tried to talk with him, but he was unable to respond. So she left to get her son from next door. By the time she returned, he was sitting in his chair in the living room, and he said, "I feel fine." But earlier, he'd had similar symptoms a week prior while he was harnessing his horse. And so they went ahead and came to the emergency department. How would you state this problem representation if you're presenting it to either your resident or you're attending in the emergency department?
Okay, so we have a 71-year-old male with an unwitnessed fall where he was dizzy and he had symptoms 1 week prior, and that prompted them to come to the ED.
Nice. So then what goes through your mind when you think about unwitnessed fall? What are the questions you have or the pieces on your differential for it? What would you like to know more about?
So I just finished my neurology rotation. So a lot of what we were doing is deciding if it was syncope versus seizure. So I'd probably want to know a little bit of his medical history. If he's had in the past, maybe that was what caused this. If he's had, we saw that he had similar symptoms a week ago. I would like to know if he fell that time, if he's been falling a lot recently. So on my differential, syncope, seizure, I'm also thinking it's possibly a TIA. So he had these kind of transient symptoms. So it's possible he's having like a mini stroke, and that's kind of changing his mental status. So especially since he had 1 week prior, that resolved. Something I'm thinking about. I'm also thinking it could be like a carotid sinus like sensitivity if he was like washing his face, or maybe when he was active like with his horse, maybe something like that got triggered, like an orthostatic hypotension, things like that.
Mollyanne, how would you fill out the differential?
Yeah, so an important history question here is also like, was he trying to defecate when he's in the bathroom, which would make me think more vasovagal. And then when he also says that he's dizzy, it's important to clarify, do you mean lightheadedness, like pre-syncopal, or do you mean vertigo, like the room is spinning? I agree, seizure versus syncope. Also, you don't want to miss stroke or TIA. It's important that you establish the timeline. Did this happen this morning, which was 12 hours ago, or did this happen 1 hour ago? Because if we do decide that this is a stroke, the timing is really important for pushing TPA. And then similar symptoms 1 week ago. Was that a fall 1 week ago? Was that just dizziness 1 week ago? I also really am concerned about cardiac etiology given his age. And so, is he having chest pain, chest pressure, diaphoresis, all of the cardiology questions. We already talked about seizure. That's an important one.
I'll add 3. One of them is serious and 2 of them are absolutely not. Actually, no, 2 of them may be serious. One would be electrolyte abnormalities, like if he was not electrolyte, metabolic abnormalities, like if he was hypoglycemic, or if he had real profound hyponatremia. And then the other one would be if there was a banana peel in the bathroom. And then the third would be if there was some kind of trauma, like if he stood up underneath the sink, or if there happened to be an intruder in the house, something that would have caused him to traumatically fall.
I'm going to add another one, polypharmacy. Did this guy recently have his medication changed? And along with that, orthostatic. Was he just discharged from a hospitalization in which he was diuresed, and this was his first morning at home? Maybe he's getting orthostatic from medication changes.
So we've kind of highlighted some of these. So can't miss diagnoses. What are you most concerned about? Katie, give us 2 on here that are can't miss for you.
Stroke would be the big one, and then probably a metabolic problem.
Yeah, I'm going to say cardiogenic.
Nice. I think that's a solid list to start. So let's go ahead and fill out some of the history and get just a little bit more information, because you're there to ask. So on further questioning of this fine 71-year-old gentleman, he denies having any chest pain, jaw pain, shoulder pain, palpitations, heart racing, or nausea at the time of the event. He had previously had a CABG 15 years before, but he's had no concerns since that time. And he has a 40-pack year smoking history. His wife denies any abnormal movements after his fall. The patient denied any urinary or bowel incontinence with today's episode. His wife verifies that, but states that a week ago he did have some urinary incontinence. He denies any mental fog, concentration difficulties, or stupor following the episode, and he hasn't had any symptoms since this morning's event. His wife noted that he's had increased shortness of breath and fatigue with exertion for the last 1 to 2 months, and he does have some leg swelling at night that resolves by morning. So, Katie, how would you go ahead and update your problem representation at this point? What would change in your one-liner?
So it sounds like seizure is probably a little bit lower on my differential. He didn't have any incontinence, didn't have kind of that post-ictal state. Something that's now higher on my differential is possibly maybe some heart failure. So maybe that's causing his leg swelling. The incontinence a week ago made me kind of think, so he's wet and wobbly. So do we maybe have a normal pressure hydrocephalus going on? But it sounds like mentally he's been pretty good. So those are just kind of some things I'm thinking about. So we have a 71-year-old male with an unwitnessed fall with prior symptoms a week ago, brought to the ED, recent urinary incontinence, recent bilateral lower extremity edema, but no post-ictal state, no other indications of seizure, and then a history of CABG 15 years ago.
Mollyanne, what can you tell me about CABG lifetimes?
Oh, I don't know. 15 years seems like a pretty old CABG.
Best data I could tell on that, depending on where it was drawn from, an artery is going to last longer than a vein, which makes sense because an artery is meant to flow in that direction. But like 7 to 10 years for an artery, and then less than that for a vein. So this guy's had a phenomenal CABG. It's lasted a long, long time. So key parts of the history, what are the things that both of you are thinking about and saying like, this is a part of history I really want to narrow my differential on?
I would say that we need to actually keep our differential fairly broad at this point. And I'm very concerned about his cardiac state, given that he is having some cardiac findings with the lower extremity edema. But, he certainly could still have an electrolyte abnormality. He could have like other causes of syncope. And I think that without doing any workup, it would still be worth staying a little bit broad at this point. It sounds like he didn't hit his head. From what we've heard, it sounds like it's less likely neuro. I would do a good neuro exam to make sure that he doesn't have a neuro deficit he hasn't noticed. But I think we can perhaps put neuro to the side for a minute if his neuro exam is indeed normal, and kind of zone in on metabolic, electrolyte, cardiac etiologies.
So past medical history significant for coronary artery disease with the CABG 15 years prior. He's had one other surgery for herniated disc. His occupation, truth, is that he is an Amish farmer who he has crops and he has cattle. And this is a true story. This is one of my patients. His kids all live close by. He had a 40-pack-a-year history of smoking, and he quit 2 months ago because his wife insisted that he did. No alcohol use. But then in his family, both his father and his mother died from heart disease in their 80s. His brother and sister with type 2 diabetes. All right, so we're moving on to the physical exam. You can tell me what you think are the pertinent positives and pertinent negatives. So Katie, go ahead and highlight for me what you think some of these pertinent positive findings are in this exam.
All right, so first glance at his vitals, they look pretty good. His heart rate's maybe a little bit high, but not super high. Blood pressure looks good, so that's good. Moving on, general HE and T all look good. Moist membrane, so not dehydrated, is good. Cardiovascular, the irregular rhythm, don't like that. So we're definitely going to want to do an EKG, see what's up with that. No carotid bruise is good. Trace inspiratory crackles, no wheezes. That could possibly just be related to his smoking history, so maybe not a huge finding there, but something to look into. Abdominal exam looks good. Trace peripheral edema. Likely, we're kind of thinking maybe an underlying heart failure, so that could be tied to that. I'm not sure what the brisk pulses means. I mean, it's good that he has pulses down there. I'm not sure what, if brisk is like pathologically too much. And then a flat affect, depressed mood. Okay, so that's interesting. So yeah, cranial nerve 7. I would want to know if that is unilateral or bilateral.
It's a great question.
And kind of residual, I don't know, residual from what, I guess.
Yep, it is bilateral. That's where the poor participation came in. Is you did the exam and you're wondering, like, did he actually try? Like, was this happening? Which kind of goes along with the flat affect, depressed mood.
Yeah. Forehead sparing?
That's a stellar question. I don't remember.
Yeah. Did his wife come and did she say he's always like this, or does she think he looks weird and flat too?
No, this is a pretty normal state of effect. She's been on him to take an antidepressant for years and he's refused.
That's some helpful history to know.
Yep. That's a great question. Yeah, which highlights the importance of having family members there.
Yeah. Just a clinical pearl, if patients, like if you're trying to decide if their face is swollen or if they're having facial drip or something like that, you can ask family members. You also can ask them to pull up an old picture of themselves. In the age of COVID, we oftentimes don't have access to family members sitting right there, but everyone has their phone. So you could say, does your face look puffy? And they're like, I don't know. And you're like, well, look in the mirror, pull up a picture. Let's see.
That's great. Yeah. All right. So you've gotten this physical exam, and we're gonna tie findings together. All right. So now we're gonna talk through some of his labs, and I'm gonna give those to you. So we ordered a CBC.
Can we actually hop back to the exam real quick, Ben?
Oh yes.
What would you expect a COPD pulmonary exam, like the most common COPD? What are you going to hear when they're not in an exacerbation?
I would be wanting to listen for if there are expiratory wheezings, and if there's accessory muscle involvement, and if the pulmonary margin is lower than I expected. Good.
And I'm also going to say the most common thing is just like decreased breath sounds, because there's so much air in their lungs, you just hear it less. So Katie, good catch on the abnormal lung exam. This is not typical for COPD, although anybody can do anything.
So we got a CBC, we got a CMP. Other laboratory assessments that you'd want to order for this patient presenting in your emergency department?
Yeah, so actually the crowd in the chat has some great ones.
EKG, chest x-ray.
Chest x-ray. Yep. Tell me what lab I'm going to want to order to go along with that EKG crowd. Troponin. Perfect. That's the magic answer. Yeah. So in most emergency rooms, you can get the EKG done about as soon as a patient with a syncope hits the door. And so that's actually going to be really helpful here. Yep, 10 minutes. You're going to get that EKG. You're going to look at it and have an idea of, is this a STEMI? Is this guy an AFib? And then they should be drawing labs probably while you're getting your history and doing a physical exam in a patient that could have something significantly wrong like this. Yeah. So also, I would really be curious about a BNP or a pro-BNP, depending on what your hospital uses, given that I'm concerned for heart failure. If his EKG looked really weird, I could be concerned about some other electrolytes, such as magnesium and phosphorus. But as long as we're getting a basic metabolic panel or a comprehensive metabolic panel, either one of those are going to hit our main top ones. Blood count's really important too. Yeah, this guy could be super anemic. He could have been having bloody bowel movements that he never told us about. So that would be important as well.
Yep. Yeah. I had a guy come in today with a hemoglobin of 8 in weakness and fall.
Yeah.
That's why.
I had a guy the other day with a hemoglobin of 2.8, and he'd had maybe some bloody bowel movements over the weekend. And I'm like, oh, you're probably fine. And he was not fine. But he was young enough that his body just compensated really well.
Yeah, very nice. So I'm only going to give you the pertinence. CBC, hemoglobin, 16.6, not anemic, almost polycythemic. White blood cell count, 10.6, which was elevated for the reference range of the hospital that we were in. Borderline, it was like 10.5 for the upper limit. On his CMP, his AST and ALT were slightly elevated to 45 and 86. The rest of the CMP was stone cold normal with normal Billy and a normal glucose of 95, no gap. BNP was 2311, which is very far above the threshold of 200 that was that hospital's reference range. Had a prolonged APTT or PTT, and then a troponin of 1.10, which, can someone tell me if that's elevated or normal and what the threshold is?
Not normal. The threshold at my hospital is, I think, 0.015.
Yeah, which will be a little different at each institution where you're at. It was 0.05 here. 0.015 is the lowest I've heard of. Intriguing. It's all dependent on the lab. The lab determines the threshold. So an elevated troponin. And so we already talked about it. We did the EKG and the chest X-ray. I wish I had the EKG to show you. I'm sorry I didn't steal it. And then they also obtained a CT head because they were worried about the fall, and they wanted to assess for 1, bleeding, 2, stroke. So they obtained a CT head as well, and you walked into the ER, so you got a CT scan. Yeah. So the EKG showed the AFib that we heard on exam, but it did not have any ST elevation, had normal intervals, and no T-wave changes. The chest X-ray showed cardiomegaly with bilateral interstitial pulmonary edema, and it said atypical infection could have this appearance, and there was no focal consolidation. And then his CT had no intrafuneral hemorrhage, no ischemia, no focal white matter hypodensities, and no acute infarct findings. It said, if you're really worried about that, you can get an MRI, which is typical radiology speak. But diffuse cerebral volume loss, which it said was inconsistent with age, rather than consistent with age. And so, given this, what questions did these studies answer for you?
So there's a lot of things. So the EKG not showing a STEMI is good, but there could be other things maybe hiding there that we're not seeing right this minute. I'd probably want to get an echo to look at his heart, especially with like the cardiomegaly, and we're thinking maybe he has some congestive heart failure and this AFib. Might want to just check a look at that. CT, so the CT head, it's good that there's no like acute hemorrhage or no like chronic subdural hematoma going on, but he could still be having a stroke, and we might not see it yet on the CT head. So don't want to think too much like, oh, he's definitely not having a stroke. So anticoagulating him, I think, would be something we could think about. Probably not TPA, because I think we're outside that window. But And because we don't have any focal neurologic findings, it's less likely, but he probably needs anticoagulation in general. Chest x-ray. So it's good that there's no like focal pneumonia, but with that slightly elevated white blood cell count, we could do like a UA, see if there's anything going on there.
That's great. Great thoughts. I'll ask you one follow-up one. So you're anticoagulating for a stroke. What else could you anticoagulate for?
AFib.
Yep. And then one other option in the guess what I'm thinking game. He had an elevated trope on the last one, so you would also anticoagulate for potential occlusive thrombus. Yeah. Mollyanne, would you add anything else to that of the questions that got answered by these lab assessments or imaging studies?
To kind of boil this down, it looks like what we're most likely dealing with is he has new onset AFib, which is likely driving heart failure because the heart is pumping less well because of the AFib. And we have the elevated pro-BNP. This is a guy who probably needs some diuresis. Can you remind me, what did his x-ray show?
Cardiomegaly, bilateral interstitial edema.
Yeah. So although his vitals look fairly good, other than maybe a little bit of tachycardia, this is a guy who, in a different presentation, could be hypoxic from a CHF, new onset CHF. He could also be in, sometimes these new CHF patients also present in hypertensive emergency. So those are two things that he's not, but like Katie said, this guy definitely needs an echo. We need to decide if we think that he has a neurologic deficit or if this is just the way this man is. Sounds like this is cranial nerve 7, just the way this man is, but which would give him an NIH of 0, and we could stop going down the neuro route. Although if we think that he does have a neurologic deficit, he is going to need, although he doesn't qualify for TPA at this time, it is probably a good idea to follow up with an MRI on this guy. And then with the troponin, he's got multiple indications to be anticoagulated. So go ahead and start the heparin. Call your cardiologist, and you're going to need to repeat the troponin in about 6 hours to trend it. Yeah, so depending on what the MRI shows, maybe thrombectomy, depending on where you're at as well. You know, you have to have access to a neurosurgeon in order to have a thrombectomy. So, and you also have to have access to an MRI machine. So if you really think that this guy is having a stroke as well, and you're not somewhere with an MRI machine, you're going to need to make some decisions about how and where you're going to transport him. I really don't think that with this presentation, this is neurologic. It sounds like it's cardiology driven with the new CHF due to AFib. This guy also needs to be on a beta blocker to help rate control him. You know, 90 something is not that high for AFib, but he does need to be rate controlled. Yeah, all the medication management for his AFib. Yeah, and echo.
Yeah, that's great. So let's hit some of these initial management. We've already touched on some of these just to fill out our slide over here. So Katie, dispo, are we admitting him? Are we sending him home? Or is he just going to hang out in the ED for observation?
No, we need to admit him.
I agree. So further workup, we talked about a little bit. We talked about trending troponins. We talked about an echo. We talked about plus minus MRI if we think it's neurologic. Sneak peek, they did not think it was neurologic, so they did not get an MRI. And then what was some of the other workup that you had mentioned, Mollyanne?
Yep, we talked about echo, trending troponins, call cardiology, especially if this is like 7 p.m. on a Friday night. They're going to appreciate the call at 7 p.m. before you're calling them at 2 a.m. with a troponin of 20. They like to know about patients instead of in the middle of the night. If you can call earlier, if it's 6 o'clock in the morning, then you may have a little bit more time to see what the next troponin is. You can trend the EKGs as well. This guy needs to be on telemetry where you can actually see what his heart rate is doing, so that you're admitting him to a telemetry floor. And yeah, those are the main things I would do for this guy.
Yeah, and then interventions.
And start Lasix. We didn't say that yet.
Our free pearl today is that Lasix is 2-to-1 oral to IV, and Bumex, bumetanide is 1-to-1 oral to IV. So interventions, we're diuresing with Lasix or furosemide. We're starting a beta blocker and giving this guy an aspirin.
Yes,
and that was based off the elevated troponin, curious history. You're like, could this be in the ACS spectrum? You get an aspirin.
Probably this guy's getting an aspirin when he hits the door before we have labs back. Unless there's any indication that this is a GI bleed, he's getting an aspirin.
Yep. Yeah. All right. So we're going to talk a little bit about treatment course and then move on to management. So cardiology was consulted. They were admitted. And the echo was ordered. They also got a carotid Doppler, kind of still wondering, like, is this sort of stroke area? They did Q4 troponins. They started heparin. And then cardiology actually requested that they hold the statins, beta blocker, and ACE inhibitor, and hold adding clopidogrel because they were wanting to do a cardiac catheterization with this guy's history of the CABG 15 years prior. And so with the upcoming procedure, they said, please don't give him clopidogrel, don't give him the ACE inhibitor yet, don't give him the statin, and hold off on the beta blocker because we don't want him to tank on us on the procedure for it. So all that we just talked about, a lot of medications. What's the importance of that statin, beta blocker, ACE inhibitor, dual antiplatelet therapy given this guy's presentation? Katie, you want to give a stab at any of those that you care for?
So I think that most of those are included in the goal-directed medical therapy for congestive heart failure. So important to get all those.
Yeah. The ACE inhibitor certainly is, and the Lasix that we gave him certainly is. And then Mollyanne, let's all just talk about the DAPT, statins, and beta blocker.
Yeah, so these are for CAD, and I really like your point on holding Plavix. The cardiologists at my hospital feel the same way, that if there's any chance that they're going to want to do a CABG in the next week, they want to hold Plavix. So we're really careful not to give it before cardiology gives their blessing. We also have a lot of access to cardiology, so that helps. So aspirin, beta blocker, unless they're hemodynamically unstable. If they're in cardiac shock, don't do the beta blocker. If their heart rate can't tolerate it, don't do the beta blocker. Ideally, hopefully you'll fix them up and be able to discharge them on a beta blocker. ACE inhibitor, if their kidneys can tolerate it, almost everybody's can. And then we already said the aspirin, the full dose aspirin, not a baby aspirin, when they hit the door, and then they will be discharged on a baby aspirin for CAD.
Yeah, and full dose is 325.
Mm-hmm. Right.
Very nice. So in this, guys, I guess we'll keep moving, and then we'll adjust the problem representation after this next little bit of information. So his troponin was trended. It started at 1.1, went to 0.83, went to 0.65 at 24 hours. She started to trend down. AST, ALTs are also trended with CMPs. They normalized as well in that first 24 hours. His O2 stats did a curious thing in that they were about 100% when he was admitted, and then they went to the mid 90s, and then went to mid 80s, and then they went back up to the low 90s during his hospital admission. And then he got the carotid Doppler. It was totally normal. And we'll pause there and ask, what do you think was going on with the pulmonary findings of the downtrending O2 sats and then the improving O2 sats? Katie, what might have been happening there?
I don't know if this would affect his O2 sats, but it would cause dyspnea if like they were happening while he was trying to sleep. So like if he was laying flat, maybe he was having some trouble breathing positionally.
Great thought.
I don't know if that would change saturation though.
It would, because it changes aeration. That's why COVID patients are on their chests if you're proning them. Some other, like what other causes could kind of reduce his respiratory drive or decrease his oxygenation?
If he was on like a lot of opioids or other medications could reduce it. And that could be something that would be more transient if it wore off. Other than that, like if he had a stroke, it could possibly cause that, but it wouldn't be transient like that probably, and it wouldn't come back up.
Yeah. Yep. Mollyanne?
What was it? How much was he diuresed over this time?
That's a great question. I don't remember the number, but he was successfully diuresed a little bit.
Yeah, so you may have been behind on diuresis initially and he got some fluid backed up. I would especially be concerned about that if he got a beta blocker when he showed up and he got kind of put into worsening heart failure.
Yeah.
What's the answer, Ben?
We don't know. That's the answer. It was never solidified. What the leading thought was kind of we were behind on the heart failure diuresis, but also like the guy was in pain.
Yeah.
And so could that have caused it? He was a smoker. He's in the hospital. He's laying on his back. All those are kind of things that we were tossing. And then also this question of like, was it poor cardiac output? Like, was he just not moving blood well?
Yeah.
And so we never actually landed on it, which makes it a fun question to ask because there's not a right answer on it.
Can we talk about the AST, ALT?
Yeah, absolutely.
Yeah.
What do you want to talk about?
Did you guys decide what that was?
I have thoughts. Katie, do you have any thoughts on why the AST, ALT would decline? Drew has thoughts.
I'm not sure. I think with the shock liver, they would be more significantly elevated. So
thousands.
Or so with like a mild elevation, this could be more chronic liver problems. So he says no alcohol consumption, but it's possible like some chronic alcoholism could cause kind of that more mild LFT elevation. It's kind of all I'm thinking of.
Yeah, you're exactly right, Katie. Shock liver is much higher. And the sort of mildly elevated, I'm always thinking alcohol or obesity as far as fatty liver. We don't know this guy's BMI. You haven't told us yet. But in this case, it is actually congestive hepatopathy. I've seen this pretty significantly in a patient with right heart failure, but basically the blood gets backed up in the liver, it stresses the liver, you get a little bump in liver enzymes, and then it gets better when you fix the heart. Yeah.
And then one of the other thoughts we had was that the ALT could have also been from the cardiac myocytes.
Mm-hmm.
Is another place that ALT can come from. Yeah. So to this point, we're going to have the big kicker. They did his heart cath. They held all the meds for it. He had 40 to 60% stenosis in the left main. Kate, are you worried about 40 to 60% stenosis? Nice. What's the number you're worried about?
More than 70?
There you go. Very good. So the left main was fine. Well, not fine, impaired. Then the LAD was 70 to 80% stenosis. The left circumflex was not fully occluded, but mostly occluded. And then the RCA was also pretty well occluded. And he had some collaterals, which was perfusing some of the heart tissue, which is why we didn't see the ST changes on examination, but he had significant vascular disease. And so now, how would we reclassify all of these findings, putting them together into a problem representation? Katie, give us our one-liner.
All right, so we have a 71-year-old male who presented to the ED following an unwitnessed fall, found to have non-STEMI and new AFib and new congestive heart failure.
Excellent. That is a delightful one-liner. And Mollyanne, what is the most peculiar part of this story?
No chest pain?
I would say so. I would say the atypical presentation, which is just a good reminder for all of us that like people present differently. In that chest pain, back pain, shoulder pain, nausea, like all that is not actually indicative of what is actually going on in the person.
Yeah.
It may be, it's helpful, but it doesn't have to be present.
Yeah. Last week I diagnosed an NSTEMI in our emergency room. The guy presented for headache, but he had a very significant cardiac history, and when he was describing some dizziness, nausea, and like lightheadedness with the headache. And so we got an EKG and troponin. He had an NSTEMI.
Yep.
So think about risk factors when people have weird presentations.
Yeah. Katie, what were his risk factors?
So he had pretty extensive heart disease with that cabbage 15 years ago, and then also his pretty extensive smoking history.
Yep, absolutely. Remarkably, and this is the part of the story that was kind of the most shocking to us, is this is the only thing in this guy's medical history. We risk stratified him. He was a little bit overweight. He was like BMI 30, 31, 32. Worked outside all day long on the farm. A1C was like 5.5. I'm like, man, how is this guy so healthy and then having these heart attacks? He was one of the healthiest elderly gentlemen I've ever seen, and then just happens to have really bad heart disease.
He had a
presumably
really
family history and cabbage. Sorry?
He had a really significant family history, though.
He did. Yep. And a 40-pack year history of smoking. So, risk factors. So what happened with this guy, and then we'll do a little bit of a discussion on NSTEMI versus STEMI management, kind of like an algorithmic standpoint of when they come in, what do you do? So cardiothoracic surgery was consulted. They did a cabbage. They continued the heparin afterwards. The troponins were stopped because they were trending down. He was started on an aspirin on a high dose or a high intensity statin, which is atorvastatin 80 or rosuvastatin 40. And he was started back on his beta blocker. His EF was 20 to 25 on his echo percent. He was in the SICU for 2 days after his cabbage. Then he was transferred to the floor for medication optimization. They chose to use amiodarone for his AFib, and they got him to convert to normal sinus rhythm. That was a cardiology decision, not a family medicine inpatient team decision. They started him on carvedilol. An ACE inhibitor was held initially because of his low blood pressure after the operation. Then he was discharged with lisinopril. They continued Lasix for his heart failure. And they started him on Eliquis at discharge for his AFib. And we had a really fun game, which I won't make you play now, but which if you're watching this, you should totally play. The guy never saw a doctor, never saw a physician, never took any of his meds, even though he had a couple of prescriptions for things. And our question was, if this guy's not going to take his meds and you could only pick one, which of these would you prioritize for him? And we had a very lively discussion in our workroom about which of these we would choose if we could only pick one for him. So he ended up going home, back to his farm. He had cardiology follow-up in 2 weeks and a repeat echo in 90 days. And after that, I lost touch with him, so I don't actually know what happened, which I wish I could find out, but it's a bummer of getting kicked out of the EMR. So let's talk NSTEMI versus STEMI with the time that we have remaining for what happens whenever somebody comes in with suspicion for chest pain. What do you do? So Mollyanne, I will let you take the lead on this discussion. And kind of walk us through what's going through your mind whenever somebody comes in with NSTEMI or suspicion for NSTEMI or STEMI.
Right. So like we talked about, people present for different things and you have to figure out why they're actually there. But anyone that you have a suspicion on chest pain, ACS needs an needs a EKG when they hit the door. and within 10 minutes. And so with a STEMI, you're going to look at that EKG and be like, hey, this is a STEMI, and you're going to pick up the phone and call cardiology right then. But then in STEMI, you're going to say, well, this isn't exactly normal. And sort of the first thing to do when you're evaluating a abnormal EKG, potentially with some ST changes that's not a STEMI, is see if you have an old EKG. Because lots of people with heart disease have had old MIs in the past. And if you look and say, well, they do have some ischemic changes, but these ischemic changes have been there since 2017, you worry a lot less. If they're new, then you worry more. And then you'll need a troponin along with all the blood count, electrolytes, and whatever reasonable things they came in for. That's on somebody that looks pretty stable. If they look very unstable, you have some ischemic changes, even if it's not a STEMI, you're going to need to, put them on oxygen if they need oxygen. Call cardiology if they look unstable with ischemic changes, even if it's not a STEMI. But if they're sitting there fairly stable, you can wait until your troponin comes back. If it is significantly elevated, then you're calling cardiology. If it's just very minorly elevated, then you're going to need to admit them to continue to trend the troponin and kind of do a chest pain workup. So if you call cardiology and it's a STEMI, the patient needs to go to the cath lab, and then you start talking about where are you practicing. So for example, at John Peter Smith Hospital, we have a cath lab. I pick up the phone, I talk to the cardiologist. It takes them 15 or 20 minutes to get into the hospital. It takes the patient about that long to get up to the cath lab, and away they go. I did my rural family rotation in Quinter, Kansas, where the nearest cath lab is an hour away by ambulance in Hayes. So then we were picking up the phone, calling the cardiologist, sending them a picture of the EKG. And they said, give aspirin, push TPA, and get them in the ambulance, and we'll open up the cath lab when you get here. And so we pulled out the TPA, we pushed TPA. They put me and a nurse on the ambulance. The guy was pretty stable, fortunately, and we drove an hour. And when we got to Hayes, we wheeled the patient straight into the cath lab, and he got a cath that afternoon. So really context matters, and talking to your friendly cardiologist if you're far away about, do you want TPA? Do you want us to just roll? There are some parts of the world where you live more than 2 hours from a cath lab, and TPA may be the best you do. But in general, the guideline is even if you can't get there within 2 hours, you eventually need to ship that patient out to where they can get definitive care. And one particular thing to mention is that women in particular have better outcomes with actually getting cathed. So the difference in better outcomes is more pronounced in women. So then NSTEMIs. So in STEMI, you can always put someone on heparin if they have an elevated troponin. You should always be talking to your cardiologist, especially if the troponin is really trending in the wrong direction. And you need to think about other things that may be affecting your troponin. One thing is drug use. We have a lot of cocaine at my hospital, and very often people will come in with elevated troponins due to cocaine. That is still ischemic disease on the heart, but some cardiologists are more reluctant to roll back to the cath lab if they know that the patient just used cocaine. You also need to be careful about giving beta blockers to patients that have just used cocaine. And then another thing to think about is people with renal disease may have chronically elevated troponins. Now, an elevated troponin should still be taken seriously, but it's not going to be cleared as well. And then also there are other causes of stress on the heart, such as a septic heart that's beating really fast, could have a small bump in the troponin that's due to the demand ischemia from the sepsis or anemia or whatever other disease process is going on. You still need to trend those troponins, and if there's concerning EKG changes, you still need to worry about the heart as well. But not every elevated troponin is caused by ACS.
Awesome. Thank you for that. That's great. So the first, just kind of to roughly summarize, first step comes with signs concerning trope, EKG, aspirin. Just give it to them. Aspirin's not going to hurt anybody. Best drug on the planet, maybe. And then you have to classify STEMI versus NSTEMI. And if it's STEMI, cath lab, especially if your hospital has it. If your hospital doesn't have it, it's transfer to cath lab, plus minus fibrinolysis or TPA before you send them. And then following, you go through all the medical therapy that we talked about with the aspirin, statins, beta blockers. I'm blanking on this. Dual antiplatelet therapy with the other one, et cetera, ACE inhibitor. That's for the heart failure, not for that. And so then on the NSTEMI side, your first question is, do I intervene? Which then you have to answer, is this true ACS or is this just stress on the heart? If you determine that stress on the heart, then you have to decide, is this invasive or non-invasive? It's invasive management or ischemia-guided management. With the invasive management, you still send them to the cath lab, just like our patient did here with an NSTEMI. And then that cath doesn't have to happen as soon as the cath in a STEMI, because you don't have totally dying heart tissue. Following the invasive or non-invasive therapy, you still do the same medical management that you do on the other side. And actually, more often than not, with an NSTEMI, they'll end up getting a multi-vessel replacement, which I found to be an interesting little tidbit, because there's generally more diffuse disease than just a one area that has an acute thrombus as in a STEMI. So there's a summary there. I'm going to pull up just a really quick algorithm slide. This is a wonderful little slide from a 2017 article in the New England Journal of Medicine titled Acute Myocardial Infarction. Great to find. It's a great review article. Talks about some of the medications, talks about some of the treatment decisions. And then this algorithm breaks you down between the STEMI side of things and the NSTEMI side of things, and whether or not your hospital has facilities or the capabilities to do the catheterization. So great little reference document and a great review article from 2017 in New England Journal of Medicine. So with that, we're at our time. Would love to highlight just a couple of teaching points that you're going to take away from the discussion. Katie, I'll let you go first.
I think one of the most important things that I take away from this is like keeping your differential broad at the beginning, especially because there were a lot of different factors that were pointing to different things, and wanting to make sure we didn't miss things. And especially with like not having a STEMI on the EKG, we could have maybe said, oh, it's not a big deal, and maybe could have missed that pretty significant thing.
Yeah, that's great, including the banana peel. Mollyanne?
Yeah, thinking about the lifetime of a cabbage, that 15 years is really old for a cabbage.
Awesome. I think mine from this case would be just the timing of when interventions need to happen. The things that you do immediately, the trope, EKG, aspirin, and then the things that should happen within 24 hours, the statin and the beta blocker. And then one thing that we didn't talk about, which I found helpful in kind of preparing for this case, was that the oxygen and the morphine components of Monabash are optional. And the oxygen's only if the patient needs it. And the morphine's been associated with worse outcomes. And there's some dispute whether that's antiplatelet activity of the morphine, which is totally new to me, or if that is just that folks who need morphine generally have worse disease. So that debate is still ongoing, but there seems to be an explanation that morphine actually worsens outcomes independent of disease severity.
If your patient's blood pressure will tolerate it, nitro is much better for pain control and safer and potentially helpful as far as increasing perfusion, whereas morphine doesn't help unless they're like really, 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 really hurting, and you have to be compassionate, and it may hurt.
Yeah. So awesome. Well, thank you both so much. And thanks to all who's stuck with us for this episode of Chest Pain on Decoding Diagnosis. Thank you all and have a great night.